And over the last 7 years, I've practiced in this model of direct primary care and served as a regional medical director for the Eastern United States. And we've had tremendous success in that model, growing from just a handful of doctors to over 216 states. Unfortunately, as often seems to happen, the company was sold to a venture capital investors a couple of years ago, and things started to change. And of course, I saw kind of a shift in the vision and mission of the company, which moved from trying to deliver better patient care, a better patient experience, and a better option for employers, a more cost-effective option, to something that was focused on providing a benefit to investors. And so I decided that it was time to follow my passion and bring this model back to my own community. So June 8th of this year, I started my own direct primary care practice, and and love what the opportunity is. So I'm just trying to kind of share that message about what is out there and available. I've had the opportunity to partner and get to know Barb, and I want to just introduce her and let her share a little bit about her journey and how she became a Health Rosetta Certified Advisor. Barb, I think you're on mute.
I'm going to unmute myself was the first thing I just said.
Perfect.
Thank you, Dr. Miller. Thank you for that introduction. I'm excited to talk about this topic. Like Dr. Miller, I have been in the profession for over 25 years, and I started my own advising firm called J.C. Rose Associates over 10 years ago. And throughout those years, also like Dr. Miller, I had become disillusioned with the state of health insurance. And every year I've had to sit across the table with my clients and with my customers and deliver, bad news about rate increases, and rate increases, anywhere between 8 to 10% a year, sometimes more. And then also having to deliver the news of, okay, well, what are we going to do about it? Are we going to shop the market? Are we going to cost shift the cost to our employees? Are we going to raise the deductible? Are we going to raise co-pays? I mean, all of those solutions just sounded like really terrible solutions and are not sustainable in the long run. And so that's why when I discovered Health Rosetta about 2 years ago, I was really excited, because this was a group of 200 advisors throughout the nation who feel that healthcare can be fixed and have the solutions available, and we share them collectively in order to help bring healthcare costs down. Not only bring healthcare costs down, but also, as important, or maybe more important, is to improve the patient experience, improve healthcare outcomes. Because it's one thing to bring healthcare costs down, but if we're not improving the experience for our employees, it doesn't seem like it's a worthy endeavor. So I'm focused on that mission of bringing healthcare costs down and improving employee experience. And many of you know that the healthcare system is broken, but I really believe that the fixes are out there, and it's not a dire situation. I currently work with companies as small as 2, all the way up to 2,000, and now I'm happy to say I'm re-energized in what I'm doing, and very excited to be working, collaborating with Dr. Miller to bring a solution like direct primary care directly to employers in our area.
Thank you, Barb. I am going to share my screen now, so hopefully momentarily everyone will be able to see the first slide. Is that correct? Tracy and Barb, are you seeing it?
I see it, yes.
Mm-hmm. Excellent, thank you. Okay, let me just adjust my settings so I can see and read at the same time. So as Barb mentioned, what we are trying to share today is this concept of transforming healthcare, both costs and experience, for you individually, your business, and your employees, if you are an employer. So let's dive into that. What we want to cover today is just a little bit about the status quo. What is the current status of healthcare? What is our vision for what it can and should be? And then talking a little bit about some real life solutions that are happening out there that both Barb and I have experienced in our professional lives that is better. And then just kind of wrap it up with some suggestions about a path forward for, particularly for an employer or an individual who wants to kind of get out of the status quo. And then we will leave some time for questions and answers. So we'll try to move through our content fairly quickly. So talking about the status quo, I don't think it's a surprise to anyone to recognize that our healthcare system is a giant luxury cruise liner that is listing badly. And you may have heard this quote before, that what we have in the United States is not so much of a healthcare system as a disease care system. And I can tell you from a physician's perspective that is very true. Our system is designed to identify and treat disease, and it is structured in a way that that is what is reimbursed most effectively. And so, surprise, surprise, that's what we get the most of, is disease care, not healthcare. Statistics suggest that 75% of our current healthcare expenditures are on things that are actually preventable. And the sad reality is the majority of the healthcare people get in their lifetime, and the majority of the money that's spent for their healthcare comes near the very end of their life, when it's not very effective. So if I were to describe the United States healthcare system in 3 words, it would be unsatisfying, unattainable, and unsustainable. So let's just unpack those 3 a little bit. Unsatisfying, I think a lot of us could resonate with the caller on the other end of this phone. Trying to access the healthcare system often feels neither healthy nor caring. And some data to support that. Many of you in business are probably familiar with the NPS satisfaction scores. That's a general customer satisfaction score, stands for Net Promoter, and it's a question of how likely are you to recommend this service to your family or friends. And sadly, the healthcare industry consistently ranks near the bottom, below most other industries. What do I mean when I say healthcare system is unattainable? Well, really, that the health we're trying to attain is not attainable, or at least we are not benefiting from it. This is a study that was done just a few years ago, showing that looking at the 11 more prosperous and advanced healthcare nations in the world, and the United States ranks at the bottom of the 11 when they look at health outcomes, health equity, and quality. They found that the United States has the highest rate of all 11 of mortality that's amenable to healthcare, meaning more U.S. residents die from poor quality care than in any of those other countries. And they identified that a major cause for these poor outcomes is poor access to primary care. And finally, unsustainable. I'm sure I am preaching to the choir on this one, but in terms of cost, we've reached a point where healthcare is unsustainable. The U.S. spends almost twice as much per capita on healthcare as all the other developed countries, and that gap continues to widen. And probably the saddest part of that is we are not getting what we're paying for, and the statistics show that we are doing much more poorly. I think the COVID crisis has also brought that to attention, that we haven't fared nearly as well as a number of other countries. And this is a common question I get, and I want to just camp out in this for a couple minutes. Why does healthcare have to be so expensive? And from my experience over the years as a physician and as a healthcare leader, I would say there's really 4 main categories. One is unnecessary care. We deliver a lot of duplicative care, reordering tests and procedures, repeating the care simply because we don't communicate well. We can't get access to the record, so we just repeat it. Overuse of care. A lot of care is delivered because it is reimbursed, even if it does not have good evidence for effectiveness. And I think a classic example everyone can resonate with is the large percentage of patients in our country who use the emergency room as their primary care setting. Defensive medicine, it's implicit in our system that we are often trained to order tests that do not contribute to the care of the patient simply to protect ourselves in case there's a lawsuit. We have a very litigious culture in our society, particularly in medicine, and physicians practice that way. And then, of course, fragmentation of care. Patients get bounced around like a pinball in our system, and that leads to a lot of unnecessary duplicative care. Second big category is administrative burden, and Barbara's going to talk a little bit more about this, but our healthcare system is bloated with bureaucracy and inefficiency. Current statistics suggest that physicians spend 2 hours in administrative work for every 1 hour they're actually caring for patients. And there's just something wrong with that. There's fraud in our system, and it comes from all aspects, from hospitals, from physicians, from vendors, billions of dollars of fraud. That's wasted money. And then the one that's most bothersome to me is the profiteering. There are just so many people who have and businesses that have inserted themselves into healthcare to extract profit. And my own personal example of the company I was working for, it was really disheartening, is, going from really trying to deliver a great patient outcome at a great value for employers to trying to make profit for venture capitalists. And that's disheartening and should not be that way. Third bucket is high-tech care, trauma care, cancer care, organ transplants, advanced cardiac procedures. Those are incredibly expensive. And it's not that we don't want that, right? None of us would want to tell a family member, a friend, or an employee that who's struggling with cancer that they shouldn't get the best possible care. But what we want is less of that, because we want less patients who get cancer, or less patients who end up with end organ damage or advanced cardiac failure. And the key to that is number 4, is preventable disease. We've already said we're spending 75% of our healthcare dollars on things that could potentially be prevented. So the only way to get ahead of that is to start to do things in advance before people get to that stage. So I'm going to turn it back to Barb, and she's going to talk a little bit about who's paying the costs for this broken healthcare system.
Yes, thank you. So what we have now in our country is status quo and how we pay for healthcare. Most Americans get their healthcare through work, about 49% of Americans. The rest, 51%, through public programs like Medicare and Medicaid. But the burden for healthcare rests solely on the backs of employers. And as you probably know, employer premium costs are rising every year. And on average, in our area, 6 to 8% every year are what they call is trend. In other parts of the country, might be a little lower or a little higher. But on average in our area, I'm sure most of you are nodding your heads right now, though I can't see you, that you're seeing these kind of increases. And what happens then, of course, is that cost shifting I talked about early when we first, at the beginning of this presentation, when I talked about cost shifting. Employers find themselves in a situation of having to shift to higher deductibles, higher co-pays, higher employee payroll deductions, or in some cases, both, which I call the worst of both worlds. Next screen, please. This is scary as heck. This screen right here, what you're seeing is over a 10-year period from 1999 to 2019, and this is from the Kaiser Family Foundation. Some of you might be familiar with their nonprofit. This is a 10-year graph showing the increase in health insurance costs for an average American family. In 1999, we're talking $3,000 a year for a family premium, and now 10 years later, we're looking at an average of $20,000, and that is just incredible. Like, where's this money coming from? How is this people? How are people even able to keep up with this? Next slide, please. What you see here is people are not able to keep up. While costs are going up at an average of 61%, wages, on the other hand, have increased less than 3% over the same period of time. And essentially what you have then is this unsustainable situation, next slide please, where you see when you're looking at the average American budget, and this is really crazy how proportionally healthcare takes a bigger bite out of the overall budget of a middle class family, shifting money away from basic needs like food, housing, and education isn't listed there, but in my mind also shifting money away from education and just creating this huge burden. Next slide, please. Essentially, I've had to sit across the table from many people who've had this look on their face, and employers that have been led to believe that the best they can hope for is merely a less bad rate increase, even though there's been little to no evidence that there's increase in underlying costs of medicine. And that is in reference to some of the things that Dr. Miller was talking about, the administrative burden of processing claims, and I'm going to talk a little bit more about competing interests that are taking up a good portion of those costs, not necessarily going to healthcare, but going to so many other places. Next slide, please. And so Eric had his slide where he spent a lot of time. This is my slide where I'm going to spend a lot of time, and I'm going to talk about probably going to make some people angry, or but essentially talk about the 4 competing interests for your dollars. And the cookies there, the cookies represent the employer's money, and that's how I look at it. It's your money, the money that you have put aside to help your employees pay for their medical costs. And you're putting money or cookies in this jar in good faith that the bulk of it will be used to pay for your employees' healthcare costs. And you also have faith, right, that it's going to be used wisely. But the truth is there's a lot of competing interests for that cookie stash. First of all, if you have a health plan and you're using a network, and almost all plans do, while it may seem like you're getting a discount, the truth is you don't really know the original price, do you? You don't know the original price of any service, be it a surgery or a diagnostic test or a hospitalization. I can give you all kinds of a nice discount if you don't know the price. I can give you a nice discount if I raise my price. So that's a problem. We don't have transparency when it comes to using network. Not only does not only having a network prevent you from knowing the price, it also prevents you from price shopping, because in order to get your claim paid, you have to stay in the network. In addition, when it comes to prescription drugs, some of those cookies go to pay a middleman called a pharmacy benefit manager, or a PBM. And you've probably heard about PBMs in the news. PBMs don't manufacture drugs. They don't distribute drugs or provide you counsel on how to use your drugs. That's your pharmacist's job. And yet the PBM is the middleman, can mark up the prescription and also skim off rebates from the manufacturer and play games with pricing. I'm sure some of you remember the debacle about the EpiPen. Another competing interest is your broker. Your broker also has a competing interest. Many brokers are paid a percent of your premium. So essentially, if your premium goes up, your broker gets paid more. Or if your broker gets paid per employee on the plan, or PEPM, per employee per month, there's no financial incentive for them to shop your plan or lower your premiums because you're going to get the same amount of money, whether they save you money or not. And finally, your insurance company has no incentive to bring your costs down either. Essentially, the Affordable Care Act mandated that insurance companies have a medical loss ratio of 20% for small group and 15% for large group. In doing this, insurance companies had to raise their prices to pump up their profit margins in order to keep the profit margins where they were. Insurance companies' stock prices have actually increased phenomenally since the passing of the Affordable Care Act. Also, as an insurance company, or one way the insurance company blocks you is you, as a small group, groups under 50, you have no access to your claims data. You have no idea why your premium costs are going up because insurance companies don't have to share this data with you because of HIPAA protections. And if your company is over 50 lives but under 100, you're going to get some data, but it's very limited and does not give you a full picture. So a lot of hands in the cookie jar. I do have a slide, the next slide I want to show. This actually makes me ill, this slide, healthcare stocks versus the broader market since the ACA. As you can see, insurance companies have done just fine since the Affordable Care Act was passed. Next slide, please. Essentially, we're in a situation where all these statistics and realities can make you feel paralyzed. Maybe you feel like if you do nothing, things will magically improve. Healthcare costs keep going up, and profitability goes down, wages are flat. However, Dr. Miller and I want you to imagine a future where we can transform the trajectory to move in a direction that is beneficial for everyone. A solution that is right here and local.
Have any symptoms? They tested everybody at check because there was a couple people that
I
had
think
it.
we're hearing another voice.
I saw her once. It was a week and a half ago when we were walking at the marsh, and we weren't like in close distance or anything because obviously I'm like one of the most cautious people. So I don't know if that matters to you.
We're hearing someone else talking. Could you put yourself on mute? Who's on the phone?
Thank you. Thank you. All right, well, I'm going to turn it back to Eric. I think I might just repeat what I said, and I want to talk about, I want everyone to imagine a future where we can transform this trajectory to move in a direction that can be beneficial to everyone. And the solution is right here, and it is local.
Yes, thank you, Barb. So, I've come to believe that if we are going to transform healthcare for our children and grandchildren, it has to start locally. There are some out there who believe that healthcare is destined to become somewhat like Amazon, right? And you just go online, you browse and find the cheapest healthcare, and it's delivered to your inbox. But I want to share with you our vision for healthcare that we believe can and should be both local as well as convenient, accessible, effective, and affordable. But probably most importantly, when delivered correctly, the local healthcare can also be a tremendous benefit and boost to our local community. So just envision with me for a couple of minutes what that could look like. And we're going to use Bob from the Builder Company of Beaver Dam, Wisconsin as our example. Sorry, let me go backwards. So one day at the job site, Bob smashes his thumb with a hammer. And because Bob's employer recently implemented a direct primary care option as the core of their healthcare benefits, Bob remembers that he can contact his doctor through an app on his phone. So he logs on to that secure app, snaps a picture of his thumb, and sends it off to his doctor. A few minutes later, his doctor responds and says, "That looks bad, Bob. I think we need to do a little video call over your lunch hour." So they do that, and the doctor can see that Bob is getting pretty uncomfortable with his thumb throbbing and turning black and blue. So he says, can you slip away for an office visit this afternoon? When Bob shows up, there's no waiting, there's no paperwork. He's brought right back to the exam room, and his doctor takes a quick look at his thumb and says, yep, you've got a hematoma under that nail. But instead of shipping him off to the ER for a procedure, he says, we'll just take care of that right in the office. They drain the hematoma, and Bob instantly feels better. But the doctor then also says, you know, your blood pressure's a little bit up, which maybe isn't too surprising given that you just smashed your thumb. But we've seen that the last 3 times you've been in as well. And I think that it's an issue we probably really need to address. So he gets him started on a safe, generic once-a-day medication that he dispenses right from the office, and Bob leaves with that in hand. No co-pays for that visit. All Bob has to pay is $4 to cover the 30-day supply of that generic medication. And they schedule Bob for a follow-up in 3 weeks so they can recheck the thumb and recheck his blood pressure. So imagine, if you will, for a minute, not just Bob, but let's think a little bit broader and think about every patient in our community. And imagine a community where every patient is able to develop a relationship with a local primary care provider, and that doctor is able to really spend time with them in order to develop some mutual trust, and that patient becomes engaged in their own health. They begin to work with their doctor to make changes that help them stay healthy. They have access to their own doctor whenever they need it. The care that is delivered is current and delivered in a way that is convenient for the patient, whether that be in person or virtually, and they're able to receive comprehensive care that's coordinated through this one doctor's office, and they never have to put off care because of concerns of out-of-pocket costs or unexpected charges. Now imagine every employer in that community that is taking an active interest in the health and wellness of their employees. They are investing their healthcare dollars wisely in ways that provide a tangible benefit to both the employees and the employer. They're offering this benefit, and that becomes a competitive advantage for them in recruiting and retention. They see the benefit of healthier, happier, and more engaged employees, and as a result of that, they're seeing reduced absenteeism and improved productivity of their employees. They also are able to develop a strategic partnership with a local healthcare professional who helps them navigate things like a pandemic crisis and how to handle that, or just healthcare issues that may arise in their employee population. And they also develop a partnership with a benefits advisor who has aligned incentives that's helping them lower their healthcare spend. Finally, how about a community where together we make sure that every person has a healthcare home, where they can actively engage in their own health, and where there's a safety net to provide care for those in need, and isn't just sending them to the urgent care or the emergency room. Imagine where we prioritize the needs of the patient in the community over our own needs or over the demands of an insurance company or a large healthcare system. Together, we're able to develop a high-value health ecosystem that becomes a major attractor for new businesses and new families who want to choose to make our community their home. And imagine a community where we all benefit from thriving schools that are no longer being gutted by unsustainable healthcare inflation year after year, and a community where all key stakeholders agree that the health and wellness of the community is a shared core value. That's the kind of community I want to see us live in. And it's possible. It really is. This is not just pie in the sky, because I think both Barb and I have seen implemented solutions that really make a difference. So let's talk about how direct primary care, how I have seen that be a tangible solution. So,
okay. I was trying to give us all.
So just a quick definition. Direct primary care has really been a grassroots movement that's initiated by physicians who've recognized that the status quo is not working. And one by one, those physicians have begun to implement a new delivery and payment model for primary care. And really, to simplify it, it looks somewhat like this. By implementing a direct payment model that is outside of the traditional insurance model, you decouple direct primary care from all the burdens and hurdles of insurance, And that allows physicians to have a smaller patient panel and significantly less administrative work. The result of that, of course, is that they are able to provide their patients with more access and availability, and they spend their time caring for patients, not doing paperwork. On a macro scale, that looks a little bit like this. Okay, we increase primary care, which results in improved health outcomes, which results in decreasing healthcare costs. And I know that seems oversimplified, but let's just unpack that a little bit. How do you increase primary care? And specifically in a direct primary care model, I would say that this is what most patients experience when it comes to accessing healthcare, specifically primary care, right? There's all kinds of barriers. You know where you want to get, but there's so many barriers put in place. Things like copays and deductibles that discourage you from accessing healthcare. When you do schedule an appointment, there's often long delays, and when you do get to the office, you're often waiting an inordinate amount of time to get seen. Poor service. I think that's just a universal experience. I had that myself recently. My mother's in her early 80s and having all kinds of health issues and being bounced around from one specialist to another. So I reached out to her primary care doctor. I faxed them the release of information so I could talk, and asked if we could just discuss some of my mother's problems and how she needs someone to take charge and help coordinate her care so she doesn't just keep getting bounced around. I think I've called the office 4 times now, and we're now going on 8 days and still no return phone call from her doctor. That's just not good service. Care is very fragmented these days, and it's incredibly frustrating to patients. Care is delivered in a way that's not convenient for the patient. It's designed for what's convenient for the system and the healthcare providers. And finally, there's become such a lack of consistent relationships, which means there's an inability to develop a trusting relationship in healthcare. And those are all barriers. What direct primary care tries to do is basically remove those barriers. And what we're trying to do is take this picture and move it to something like this. So there's still a journey that people have to take for their healthcare, but we need to remove as many barriers as possible. How does that result in better outcomes? Simple. Time. Physicians are trained to help people navigate the healthcare system and help them achieve better health outcomes. That's what all our training is geared for, but you have to have time to do that. You can't get the typical 7 minutes in front of your doctor these days and expect to have a meaningful interaction and better health outcomes. And how do we then lower costs? How does direct primary care help lower costs? Well, we talked about those 4 main categories. Direct primary care really helps eliminate a lot of the unnecessary care because you have the time to quarterback your patient's care. We already talked about the administrative burden, and what direct primary care does at its core is cutting out the middleman and saying, let's spend our healthcare dollars actually on care. High-tech care, well, we don't want to limit high-tech care. We simply want to need less of it, right? And that really comes back to preventative care. Primary care is by far the most effective healthcare and most cost-effective healthcare we have because it's focused on prevention. When you can start putting care on the front end and helping people avoid disease, you can save huge amounts of money down the road. And it's also better for patients, right? You don't want to run a race and start training for it the morning of the race. You need to start that much in advance, and it's the same thing with healthcare. We need to help our patients take their health seriously and do things in advance that are going to keep them out of the high cost and high disease care. Barb asked me just to share a little bit of what does it look like in real life? What does a direct primary care office look like, feel like, what happens there? Well, it looks a lot like a regular doctor's office, but what you'll notice is it's smaller and less crowded. And most importantly, it's not limited by those 4 walls. Because we don't have to follow the healthcare insurance rules, we can deliver care in any way that's convenient. You call after hours, you get your doctor. That care can be delivered in any way that makes sense, by phone, by text, by email, by video visits, or of course in person when needed. When you do come into the office, it feels a lot more personal. You're known by name, you're not a number, and it's a lot simpler, a lot less forms to fill out, a lot less phone trees to navigate. no confusing or opaque charges or unexpected follow-up bills. It feels like there's a lot less hurdles between the patient and their doctor and getting the care they need. And what happens in a direct primary care office? Well, more than you might expect. It focuses on a lot of prevention, adult physicals, well child physicals, sports physicals, chronic care management, behavioral health screenings, wellness care, but also we do a lot of acute care, acute injuries, illnesses, lacerations, rashes. We can do a lot of procedures in the office, skin biopsies, removals, skin tag removals, toenail removals, wart treatments, a lot of things that get shunted to specialty care in the traditional health system. We can do because we have the time and it's all included. And finally, most importantly, care coordination. So when someone does need a pre-op physical, we can take care of that. When they need post-hospital care, we can help manage all of their care, and that keeps things much less confusing and complex for patients as they navigate our healthcare system. Turn it back to Barb for a few minutes just to talk about real-life solutions for health plan options.
Thank you, Eric. I think now I think you can see clearly how having an involved and accessible doctor in your community can create healthy outcomes for patients and at the same time lower costs. And I think at this point you might be wondering, but how do I add direct primary care into my current health plan? I get that question a lot from my clients. Do I have to change my current health plan to add direct primary care? I know many employers really love the idea, but they have wondered these questions. Well, the answer is that direct primary care can be added to almost any plan, but it does work better and is more cost effective in certain types of plans. And I'm going to talk about that. Certain types of plans where you're going to have a greater impact on the on patient outcomes and on cost. If I go to the next slide. So essentially, when you're looking at health plans, they fall in one of these four buckets. A fully funded plan is a plan that most people are familiar with as a traditional health insurance plan, or kind of like the status quo. Level funded plans are a plan where a part of the premium is I hate saying this word, but this is how it's described, at risk. And then self-funded is a plan that's completely unbundled and then recreated and reimagined by the employer. And you then own your data and you're able to create a plan that would incent your employees to have better healthcare outcomes. Another type of, another fourth bucket is medical cost sharing. And I'm discovering that a lot of employers don't necessarily know a lot about medical cost sharing, but it is really a wonderful way to pay for healthcare costs. It's not an insurance solution. It's a membership-based solution. So direct primary care can really be added to any of these four options. Personally, and I feel self-funded and medical cost sharing are probably the best way to go to add direct primary care. However, we have added direct primary care to basically any kind of plan. I have a couple of case studies that I've done I want to share with you. My first case study, I used medical cost sharing and then added a direct primary care option along with it. So this is a small Madison construction company that I worked with. Every year, for the past 8 years, they got a health insurance premium increase somewhere in the neighborhood of 8 to 10%. And in 2019, they came to me. They weren't my customer at the time, but they came to me and said, you know, we're just tired of this. Our employees' out-of-pocket costs are $4,500 on a single, $9,000 for a family. On top of that, they had co-pays for office visit and prescription co-pays. All of those were ongoing. What I did is I introduced direct primary care and I added in medical cost sharing. So as Dr. Eric has explained, the direct primary care handles many of your primary care, as DPC suggests, whereas a medical cost sharing will cover or help in paying for those large claims like hospitalizations and surgeries. Essentially, what we ended up doing is we designed a plan that had zero out-of-pocket costs for primary care. It had unlimited office visits, prescriptions at cost, and no network. You remember me talking about how the network really was actually a detriment to having a plan that was cost effective. And here's the net result. If you could go to the next slide, please. Essentially, what I did is, this is what they were paying, and I don't mind sharing any of this. Their current plan with Quartz, they had a small group of 4 people. We put in direct primary care. Sedera is a medical cost sharing company that I use. 500 is essentially, IUA stands for initial uninsurable amount, think deductible. And so you can see the huge savings there. Even with the richest plan that I proposed, it had a 50% decrease in costs. And then there was another plan I presented that was 61, but they went ahead with the 50% because that was a really good plan for them. Next slide. Essentially, what happened, it made me so excited. The employees saved money, the employers saved money, the out-of-pocket that the employees had to pay was reduced. Better healthcare. I had dinner with the owner of this company about 6 months ago, and I had put on my calendar for an hour to talk to him about how things were going. We were there for 2 hours because he had story after story about the better healthcare outcomes that he had gotten, and I have to tell you that more than anything made me so happy. He had more choice because there was no network, and with his savings from this plan, he actually added a dental plan for his employees. So he took that money and invested it back into the employees, and what a wonderful outcome all of that was. Next slide. Here's another solution where direct primary care works really well, is in self-funding, and essentially the employer will unbundle their fully insured plan and cover most of the employee's bills under a fixed amount, say like $50,000, for example. The employer then buys an insurance plan for the larger claims they may face. The employer, with the help of a benefits advisor, designs the plan to align incentives for the employees to utilize a DPC doctor. And using a DPC doctor does prevent overutilization. They did a study of the population. Here's a study of a population. Next slide, please. A population of 165 people. This company is Nebraska Plumbing Company. After 1 year, this is a kind of outcomes we're looking for. Not only cost savings, as we keep saying over and over, not only cost savings, but better employee, better health outcomes. You're seeing less ER visits, less admits to the hospital, a lower blood pressure, a better triglyceride and blood glucose outcomes, because the employee's health is being managed by a direct primary care doctor. So those are just 2 examples of how we can use direct primary care inside a plan. There are other ways to add it to a fully insured plan or a level funded plan, which is essentially is increasing your deductible. But I would talk a little bit later about steps you can take to start to unbundle some of this and really see the benefit of putting direct primary care in your total health care package for you and for your employees.
Barb and Dr. Miller, I just want to give you the 12-minute notice.
Yes, thank you. I'm sure Barb and I could probably talk 4 hours on this. As she mentioned, we're both very passionate about it. So we're going to just wrap this up with, we'll take no more than 1 minute for each of these next 2 slides, and just, what is the path forward if you are saying, I'm tired of the status quo for myself or my employees. From my perspective, it's a call to action. We can't be stuck in learned helplessness anymore. The task is not insurmountable, but we can't wait for our dysfunctional political system to solve this for us. We have to do it locally. We have to align incentives. What's good for our healthcare is actually good for everyone. A rising tide raises all ships, and it has benefits that will be a win for patients, for employers, for the healthcare community. We need to invest more strategically in healthcare. We can't just be stuck with the status quo and hope for less bad next year. And I think together we want to see strong schools. We want to see healthy diversity in our community. We want to see a thriving business community. And I think one of the best places to start that journey is building an affordable and accessible healthcare options for our community. And Barb, yours path forward?
Yeah, I kind of referenced some of this not too long ago, but the path for adding a direct primary care solution to your company's health plan is relatively easy. First, what you want to do is determine the funding mechanism that you currently have in place to cover large bills like surgery, hospitalization, and specialty care. Is your plan fully funded, level funded, self-funded, or are you using some form of medical cost sharing? If you're not already self-funded or using medical cost sharing, then I encourage you to take a serious look at those programs, as they can save you between 20 to 40% on your overall cost. You can get a handle on the cost of healthcare and help put data back in your hands about how much you are spending, where you are spending it, and then add direct primary care to your plan and incent your employees and by restructuring your employer contributions to the plan. Also, is your broker/advisor transparent? Are they aligned? Are their incentives aligned to save you money and create better outcomes for your employees? Ask yourself that question. If the answer is no, there's definitely one place that you should be looking.
Thank you. Yes, we have about 9 or 10 minutes left, but I know Barb and I are both willing to stay on if people have additional questions, but we would open it up at this time for questions. Either unmute yourself or you can chat questions.
Is there anyone that would like to start that has questions? Otherwise, I actually jotted down a few here, so I'm just curious, probably maybe for Dr. Miller here. It sounds like this is a great way to go for your primary care, but help me understand why you can't still, accept traditional insurance.
Yes, great question, because I get that all the time. People say, wow, this sounds excellent. I'd like to. The problem is with traditional insurance comes all the regulations and problems. And I mean, that's why physicians are burning out, is by its nature, traditional insurance requires you to have very large panels to see patients very quickly. So much of the cost is going to all these other hands in the cookie jar that physicians simply have to see patients very quick and have very large panels of patients, which means you can't really invest in your patient's care when you're doing that. So it's kind of par and parcel to the whole thing. You have to decouple yourself from traditional insurance in order to offer this kind of care.
Anyone else have some questions? A second to unmute. Anyways, it was kind of a two-part question for me too. What happens if someone needs to see a specialist? What happens?
Yeah, and I think Barb kind of alluded to that a little bit, is that's why it's important. Direct primary care can do so much. We typically say, 80 to 90% of your healthcare needs can realistically be delivered through a direct primary care office. But bad things happen, accidents happen, surgeries required, hospitalizations. People need to have health insurance of some type or medical cost sharing that protects them from those catastrophic events. But so we work within that. If someone has an outside insurance plan or cost sharing, we try to help them figure out when they do need additional care, what's the most effective way to get that. And again, like Barb said, often if you're not limited to a network, we can say, gosh, you can go here and get that procedure, that imaging done for $2,000, or we can send you over here and they'll do the same procedure for $600. So we do try to kind of leverage our knowledge and experience to help people get the best value for their dollar, even when it's happening outside of our direct primary care clinic.
I have a question here too. Can one use DPC with Medicare?
Currently, Medicare is the one place where we are not allowed to do DPC, and the reason is that Medicare, of course, says if you're accepting Medicare payments for patients, you can't charge them any additional fees. Now, there actually has been interest on Medicare's part, and before I left my large company in my role there, Medicare had reached out to us and said, we would like to do a pilot because we see the tangible benefits of direct primary care, and we would like to see if we can figure something out for Medicare patients. So I'm hopeful that down the road there will be an option, but as it currently stands legally, you cannot, if someone has Medicare as their primary insurance, you cannot charge them a DPC fee to be part of your practice.
Anyone else have a question? Oh, I have someone that says that they would like to be part of the pilot, so I will make a note of that.
I'll let you know when Medicare comes back around. We'll see.
And also another comment that just wanted to thank you both for this great talk. The model will be great for the Beaver Dam area. Any other questions? Otherwise, I had a couple more I jotted down.
I had a quick one. So, Dr. Miller, if you do need additional tests, right now when I look at my insurance, I see the cost of the test and then I see the cost that's charged because I have my insurance. So, are you able to negotiate costs at all for those additional things? Do you know what I'm saying?
Yeah, that's a great question, Mary. And interesting, and Barb, I think, alluded to it a little bit, but I know she had some other slides that we didn't even cover that talk about that lack of transparency, right? And how there's just a lot of fuzzy math that goes on. I'll give you a perfect example. So I have a lab service that I draw labs, send out labs for people, right? And some of those are covered by a membership fee, some screening labs. So patients of mine, get their cholesterol panel and that all covered per year, but sometimes they need additional labs. And what we've discovered is, so if I draw a chemistry test on someone and I run it through my bill, through my client billing, right? I get charged $4.40 for that chemistry panel. If the patient pays it, it costs $46. And almost universally, there was a tenfold increase if patients were paying. So, of course, what I do in my practice is I say, hey, we need to do some extra lab work. You pay us for it, and we'll charge you $4.40. If you want it to go through your insurance, they'll charge you, $46. Which would you like? And people are like, great, I will pay, here's the $4. So there's just all kinds of ways that you can, get those discounts. And we often will try to not only do that, but leverage our knowledge of the system. Medications is another great one. I have a patient who recently saw me and said they're just picking up their over-the-counter, Prilosec for their heartburn. And, it costs them $26 a month to get their over-the-counter. I can get them a 30-day supply through my vendor for $4. And so, they're like, great, I'll take it from you. And so there's just so many ways that things are so overpriced in our system. And as Barb alluded to, the lack of transparency of costs is just maddening to people, I think.
Thank you. Do you have trouble getting access to any medications as compared to a large conglomerate or anything?
So we carry medications in the office. Obviously, as a small practice, we don't carry, a pharmacy's worth of medicines. We carry the common ones. generic versions of things that people might need acutely. I don't want to be a pharmacy for people. There's excellent pharmacies in town that do that, but it's really nice for a parent to come in with a child who's got an ear infection and be able to walk out the door with their antibiotic in hand and not have to make another stop. So we try to kind of tailor our formulary to the common ones people will need, and that could be an acute advantage to them. A new start, my example of, Bob needs a new blood pressure medicine. It's really nice for him to be able to walk out of the office with it and say, all right, give this a try for the next 4 weeks and we'll touch base again. But yeah, I do have arrangements with, other vendors where we can get people medications at discounts, even if I don't carry it in the office. So great questions though.
Thank you.
Someone had asked about, can we get contact info for both of you? And I think we can follow up this call with that particular information. And they also asked about annual fees for individuals with no employer insurance.
Sure. And yes, and we have end of the slide. We switched back to the video view, but I can switch back to the last slide. Has our contact information on it, and certainly this presentation is going to be posted, right, Tracy? So
yeah,
people
hopefully by tomorrow, and I'll send everyone links and also your contact information.
Great. But yes. And again, I specifically, I don't want this to be a commercial for my practice. I simply believe this is a model that is good for our community. And I can only take care of so many patients, but I would love to see our community move in this direction. And I know that the physicians who are getting burned out in the traditional system do and would love this model to practice in. So each physician can set their own fees, for what that is. And interesting, in contrast to the premium reductions, I was giving Barb this example recently, is that, when I started in this 7 years ago, the fee that the company I was working with out of Denver was charging was, I think it was $124 a month for a membership fee. If you had considered inflation like we've seen with our premiums over that 7 years, that fee would now be just under $200. Whereas in my practice now, the fee I charge is less than half of that. And so, things don't have to just keep inflating in healthcare. There's not a need for that. You can get a really great value through a direct primary care membership that provides a tremendous amount of healthcare for a flat, simple fee, with no surprises, and employers love it because they kind of know what they're paying up front. There isn't these opaque charges and bills that they couldn't see coming. So
I know we're at the time, so everyone is welcome to stay on. And I have one question that I wanted to ask, and that was, what is the first step for an employer? Because I think these renewals happen January 1st. If they wanted to look at, going this model, how do they start moving that direction?
I think that's in my question here. You can really look at this model anytime. I mean, you don't necessarily have to wait for your renewal, though that's usually when employers take the monster out of the closet and take a look at their health plan. So in doing so, the best thing to do is, like I mentioned, is to take if you're working with an advisor or a broker, speak to them about direct primary care. Ask them if they know what it is, and tell them that you're interested in adding it to your plan, and go that route. And if they don't know what it is or don't understand it, I'm happy to be a resource for them for that. And but essentially what you want to do is get a handle on what kind of mechanism you have right now for paying for those large claims. And you really need that to pair with direct primary care, because as Dr. Miller said, you're going to possibly have, expenses that are going to be hospitalization or surgery or things like that. But just start to break it down right there.
Mm-hmm.
We have a lot of small employers in Beaver Dam who maybe can't do the self-insured route, would it make sense for them to consider something like this, you know, versus like a fully insured plan?
Yeah, so what works really great for small groups is medical cost sharing. And I don't really have a lot of time to go into what medical cost sharing is, but medical cost sharing plans have been around for decades. They started in the faith-based communities, and some people might be familiar with those. And they work really great with direct primary care because also medical cost sharing does not have a network, which again is essential to being able to use the direct primary care. It's not crucial, but I would suggest taking a hard look at medical cost sharing for smaller groups. And then if there are ways you can pair medical cost sharing too with a traditional health plan as well. So there really isn't any excuse not to add direct primary care to your plan if you want to.
I had a question here from Jenny. What if you have an individual membership and you end up getting an ambulance ride to the hospital?
Is that you, Barb, or me? I'm not sure.
Yeah, that's a good question. Well, you know that is not that's not a primary care visit. That's a hospitalization. So that wouldn't fall under direct primary care. That's acute care. And so in that situation, again, that is why you would need another plan to go along with the direct primary care. So either you would have a fully funded plan, or you would have a medical cost share plan, and that those plans would then cover the larger bills like an ER visit and an ambulance ride.
And I would just add to that I think the secret to that is that, you know, yes, those things happen, but so many times they happen unnecessarily because we don't have good access. And as I mentioned before, so many people end up using the emergency room for primary care needs because they have no relationship with the primary care office, or they're just not accessible, or they call and their answer is go to the emergency room, right? You know, what in direct primary care, we do everything we can to keep people out of those settings because many times it's not necessary. Many times it's not the best care for them, right? I can care for patients so much better who I know them and I know their medical history, and I don't have to start from square one and repeat all the tests. And I can tell my patients, you know, when it's something really serious and when it's something that, okay, this can probably wait till tomorrow morning when we can see you. Many direct primary care practices like mine, you know, provide a lot of alternative access hours. I mean, I have done this many times in the last 7 years where a patient calls me after hours and I say, you know what? It's going to be easier, cheaper, quicker, and better for you to meet me at the office than it is to go to the emergency room. I'll see you there. You know, I can put the stitches in, I can swab your throat, I can, it just makes so much more sense to do that. And now obviously if they're having, you know, crushing chest pain or they're bleeding profusely, I'm going to send them to the emergency room. But the vast majority of the people walking through the emergency room don't have true medical emergencies.
Hey, any last questions before we call it a day here? And thanks for staying on a little bit longer here.
And Tracy, I would just say, you know, I know both Barb and I are happy to answer individual questions people have. Email us, call us. I think both of us really want to be resources to people, and you know, whether they are going to ever use our services or not, if we are both passionate about this model and transforming healthcare. So if we can be of assistance to people and just providing counsel or pointing you in the right direction, please reach out to us.
And do you want to close with putting your contact information back up there? Would that be a problem?
Absolutely, I can do that. Let me share my screen.
I will also email it out too.
There we go. So you should be able to see that now. And yeah, happy for either of us to talk anytime. Thanks for setting this up, Tracy. We appreciate it.
You bet. And thanks everyone for joining us, and look for future business power hours and join us again. Thanks so much.
Great job, everybody. Nice information. Thanks so much.
Thank you.
I'm just going to sign off then. Bye.